A very good afternoon, everyone. And we welcome Sir Dr. Mark Haas. He has come all the way from California, Los Angeles, which are approximately 8,000 miles from here. And all the way, thank you, sir, for coming here and welcome to Calcutta. And sir, today he will be presenting on diagnosis of antibody renal allograft rejection, the evolution of BLAM over last 30 years, where we stand today. Over to you, sir.
Thank you very much. Appreciate it. Thank you very much for the organizers for inviting me. And I hope that perhaps by the end of the talk, I may have convinced at least some of you to trust your pathologist in terms of generating information to treat your patients. These are my disclosures. Now, antibody-mediated rejection was a big problem in the very early days of transplantation. I'm talking about 60, 65 years ago, before we had mechanisms for detecting the presence of pre-existing antibodies against the graft. And when an organ was transplanted in a patient who had these pre-existing antibodies, they developed a process called hyperacute rejection, which was characterized pathologically by inflammation and damage to the microvasculature. So we see here in the glomerular capillaries, can you see my pointer? Yeah, so in the glomerular capillaries, we see thrombosis, we see leukocyte margination, and very similarly in the peritubular capillaries. And then, for the most part, the transplant community largely forgot about antibodies for about 25 years. And the initial iterations of the Banff classification for transplant rejection focused almost entirely on T-cell mediated rejection and ignored antibodies until the 1990s, when studies such as this from the Halloran group, maybe this is better, studies such as this from the Halloran group in Edmonton identified differences in acute rejection. I'm not talking about hyperacute rejection, I'm talking about months to years post-transplantation, in the presence or absence of anti-HLA antibodies. In the absence of such antibodies, the rejection episodes were dominated by T-cell containing interstitial infiltrates and tubulitis. But in the presence of such antibodies, these lesions were often absent, and what we had instead was margination of neutrophils in the glomeruli, peritubular capillaries, glomerular fibrin thrombi, in other words, microvascular inflammation, similar to, although not as severe, as hyperacute rejection. And these are the hallmark lesions of active antibody-mediated rejection in the kidney. Microvascular inflammation, infiltration of leukocytes. They can be neutrophils, they can be CD68 positive monocytes in the peritubular capillaries and also in the glomerular capillaries, largely occluding the capillary lumens. And if we do an immunostain for CD68 here on an adjacent section, we can see CD68 positive cells in these capillaries. But microvascular inflammation, as I'll stress later, is not specific. It is a marker really for microvascular endothelial injury, which can be due to antibody-antigen interaction, but could also be due to recurrent disease, could also be due to severe calcineurin inhibitor toxicity, and thus pathologists were very excited when C4D came along. C4D is a degradation product of C4, which is part of the classical pathway initiated by antigen-antibody interaction, and although C4 C4D itself is biologically relatively inert, it remains bound at the site of C4 cleavage for about 2 weeks, and thus is a relatively long-lived marker for a humoral response that's easily detected by immunofluorescence or immunohistochemistry in tissue sections, such as this bright staining for C4D in the peritubular capillaries. And with the advent of C4D staining, a number of studies were done here in the early 2000s showing C4D staining to be highly specific for the presence of donor-specific antibodies, although the sensitivity varied quite greatly, in part because of different techniques used to detect C4D. So finally, in 2003, the Banff community got around, about 12 years after the initial Banff report, to define criteria for antibody-mediated rejection, and 3 different sets of criteria were required. Morphologic evidence, specifically microvascular inflammation, glomerulitis and peritubular capillaritis, sometimes with thrombi could substitute for this, immunohistologic evidence in the form of C4D, and finally, circulating antibodies against the graft, donor-specific antibodies. And these criteria remained in place for about 5 or 6 years until people started noticing that even in the presence of donor-specific antibodies, a fair number of kidney transplant biopsies showed microvascular inflammation, but no C4D, and thus could not be called antibody-mediated rejection. And a number of studies really sort of changed the field that were done in the late 2000s, early 2010s. This was actually an important study by Alex Lupi and his group from the Paris transplant group. And the purpose of this study was not to look for C4D negative antibody-mediated rejection, but actually to look at protocol biopsies and see if there was such thing as subclinical antibody-mediated rejection in a normally functioning graft. And in Paris, they do protocol biopsies at 3 months and 1 year in all their DSA-positive patients. And in this study, they looked at the 1-year biopsy findings as a function of what they saw at 3 months. At 3 months, they had some patients whose biopsies completely met the Banff 2003 criteria for antibody-mediated rejection. They were C4D positive, they had microvascular inflammation, they had donor-specific antibodies. Some of the patients had no C4D or microvascular inflammation, and there was a significant group that they called suspicious but not diagnostic that were C4D negative but had microvascular inflammation. Well, how did these groups behave at 1 year? Well, the no antibody-mediated rejection group had excellent graft function. None of them had transplant glomerulopathy, a marker associated with chronic antibody-mediated rejection, and only a small number had mild interstitial fibrosis and tubular atrophy. Those that met all of the diagnostic criteria had poor graft function. 100% had interstitial fibrosis and tubular atrophy. Nearly half had transplant glomerulopathy. This suspicious group that was C4D negative but with DSA and microvascular inflammation actually behaved more like the subclinical AMR group. They had lower GFRs, most had interstitial fibrosis and tubular atrophy, and a few even had transplant glomerulopathy. So in BAMF 2013, they modified the criteria for active antibody-mediated rejection, no longer specifically requiring C4D, but now accepting alternative lesions as meeting this second criteria of current or recent antibody interaction with the endothelium. A higher degree of microvascular inflammation was one of them. The other was molecular evidence, and I'll talk about molecular diagnostics a little bit later. Biopsies meeting 2 of the 3 criteria were designated as suspicious. This threshold of MVI, glomerulitis plus peritubular capillaritis of at least 2 was confirmed in this molecular study looking at expression in the graft of transcript sets associated with antibody-mediated rejection, and one can see while the very mild microvascular inflammation was not significantly associated, when this higher threshold of 2 was required, most of these gene sets were in fact positive. But active antibody-mediated rejection is probably not our biggest problem. Our problem is chronic antibody-mediated rejection, as illustrated here by transplant glomerulopathy. Double contours of the glomerular basement membrane as evidenced on a silver or a PAS stain, which is felt to be the hallmark lesion for chronic antibody-mediated rejection. And this is associated here in many studies, this one from the Mayo, with poor graft survival. And it's also associated with anti-HLA antibodies, particularly antibodies against class II. The problem with diagnosing transplant glomerulopathy from a pathology standpoint and a clinical pathologic standpoint is it's rarely evidenced before 1 year post-transplant. And given its negative effect on graft survival, is there any way to pick it up earlier? Well, this is a very nice study that came actually out of Sydney, Australia, by 𝐌𝐚𝐿 𝐸 and his colleagues. And like in Paris, they do a lot of protocol biopsies in Sydney, and they do protocol biopsies at 3 and 5 years. And what Brian and his colleagues did is they identified patients who had over-transplant glomerulopathy at 3 and 5 years, and then went back to their 3-month protocol biopsy, the stored tissue, and performed electron microscopy on it. And they found, in fact, 3 different morphologic lesions by electron microscopy that correlated with subsequent development of transplant glomerulopathy: endothelial cell swelling and vacuolization, subendothelial electron-lucent widening, and early basement membrane duplication, these fine wisps, too fine to be seen on a silver stain. What we then did is looked at these lesions that were identified in early 3-month biopsies in patients with donor-specific antibodies and looked to see it did in fact the presence of these 3 lesions correlate with subsequent development of overt transplant glomerulopathy. And in fact, some cases yes, and some cases not necessarily. And the difference was whether or not the patient was treated at the time of this early biopsy for antibody-mediated rejection. If they were not treated for antibody-mediated rejection, they invariably developed transplant glomerulopathy. If they were, then about 2/3 of these patients did not subsequently develop overt transplant glomerulopathy, suggesting that transplant glomerulopathy, if caught at a very early stage before it's evident by light microscopy, can be arrested. So these are the BAMF 2013 criteria for chronic active antibody-mediated rejection. There needs to be evidence of chronic tissue injury, mainly in the form of transplant glomerulopathy. These other lesions, peritubular capillary basement membrane, multilayering, which is analogous lesion to transplant glomerulopathy in the peritubular capillaries, or arterial transplant fibrosis, are not as specific as transplant glomerulopathy. there needs again to be evidence of recent antibody interaction with the endothelium and donor-specific antibodies. And this study from Quebec City confirmed the superiority of these new criteria for antibody-mediated rejection versus the older criteria that required C4D. Not surprisingly, a higher number of biopsies were found to have evidence of antibody-mediated rejection because C4D negative lesions were accepted, but also there was a much stronger correlation with a combined endpoint of graft loss or doubling of serum creatinine. So definitely, clearly an improvement in the criteria. But even BANFF 2013 had its gaps. What to do, for example, with a biopsy showing microvascular inflammation and no donor-specific antibodies? I mentioned before, microvascular inflammation is not at all specific for antibody-mediated rejection. In this study, only about 50% of biopsies, even meeting the threshold of 2 for microvascular inflammation, were DSA positive. And only about 3/4 of patients with transplant glomerulopathy will have evidence prior of antibody, and there are other lesions that can cause glomerular basement membrane duplication, such as thrombotic microangiopathies and anticardiolipin antibody-associated hepatitis C. C4D could be potentially a surrogate marker for DSA, and this study from the DCAF study, a multi-center study in North America, showed that graft survival was decreased in the presence of C4D positivity, whether or not donor-specific antibodies were present. So in 2019, the BANFF group agreed with a plurality of 82% to accept C4D positivity as a surrogate marker for donor-specific antibodies. What else might be done in such a case? Well, one potential solution is to test for non-HLA antibodies. In this study that was published in 2019, the majority of patients with G plus PTC of at least 2 and no anti-HLA donor-specific antibodies had antibodies against the angiotensin type 1 receptor. The other thing that might be considered is molecular testing. As I mentioned, the group in Edmonton has been a large proponent of this, identifying gene sets correlated with both antibody-mediated rejection and T-cell-mediated rejection, and developing molecular classifier scores for each of these. The molecular classifier score for antibody-mediated rejection is primarily genes expressed in endothelial cells and NK cells, both known from experimental models to correlate with AMR. And when they looked at this molecular AMR here, and again, this is not totally cooperating, but the best correlation with reduced graft survival was found both when the molecular score was positive and when the histologic score showed evidence of AMR. The best survival was when there was no molecular evidence of antibody-mediated rejection or no evidence of microvascular inflammation. When one of the two was present, the results were intermediate, but actually the molecular score was a better predictor than microvascular inflammation of graft loss. So in 2019, this term was modified, accepting C4D staining as a surrogate marker for DSA, and also accepting molecular diagnostics, this classifier, as a surrogate marker for DSA. But one of the problems with BANFF is that sometimes we, in our haste to improve the classification, get a little bit ahead of ourselves. And I think BANFF 2019 was a prime example of that. Not only accepting the molecular markers as surrogates for DSA, but also eliminating the suspicious for antibody-mediated category of BAMF 2013, which seemed problematic at the time, but maybe wasn't as big a problem as we thought. These are data expressing transcripts in biopsies with different levels of microvascular inflammation from the Halloran group, and these are DSA positive biopsies. These are DSA negative biopsies. And as these genes that are expressed heavily in biopsies showing microvascular inflammation, their expression is not much different whether there's DSA absent or DSA present. Thus, these genes are markers for microvascular inflammation. They are not specific for antibody-mediated rejection. And in BAMF 2022, the molecular markers are being taken out as a surrogate marker for DSA. The other problem was perhaps premature elimination of the suspicious for AMR category. Here we look at BAMF 2013. This is no AMR. This is AMR fully diagnostic. The suspicious category is here, was eliminated in BAMF 2017, but we see that this suspicious category is associated with a somewhat worse prognosis than no AMR, and thus perhaps there needs to be a better explanation of this category rather than just its elimination. And there are now at least 3 different potential causes that have been identified for the presence of microvascular inflammation in the absence of DSA. I mentioned non-HLA antibodies. The other, which was identified by the group in Martin Naessens and his colleagues in Leuven, Belgium, is missing self, that is inadequate communication between the HLA-mediated signals and recipient NK cells, and patients who have this lesion tend to have a greater likelihood of microvascular inflammation, but their prognosis is better than those patients who have DSA. And then the group in Leuven also found that patients who had very high levels of HLA mismatches had a tendency to have microvascular inflammation in the absence of HLA DSA. So although these lesions are not technically antibody-mediated rejection, they should still be included in the BAMF classification, and that's what has been done in BAMF 2022, where this suspicious category was now replaced by a more descriptive term of microvascular inflammation, DSA and C4d negative, and hopefully will stimulate additional investigation into the significance and response to therapy of this lesion. Finally, I must conclude by saying that BAMF is a diagnostic classification. It is not a prognostic classification. So although a lot of people have used the different BAMF grades to try and prognosticate as far as the likelihood of a patient progressing to graft loss or responding to therapy, it is really just a diagnostic classification. That said, we have taken a couple of stabs at trying to simplify the classification from a prognostic standpoint. The classification has gotten very complicated with all these different categories, and I only talked about AMR. T-cell mediated rejection is a whole separate lecture. So in this case, we looked at a number of biopsies from 2 different sites, from our center at Cedars-Sinai and the group in Paris, and developed a chronicity index. And these were all DSA positive patients who fully met criteria for antibody-mediated rejection. And what was found, that is, we took a chronicity index based on absent, mild, moderate, severe of interstitial fibrosis, tubular atrophy, transplant vasculopathy, and a double-weighted term of transplant glomerulopathy when the chronicity index was less than 4, regardless of which terms comprised this index. Even if there was mild transplant glomerulopathy present, these patients had a good outcome. Patients who had a chronicity index of 4 or greater, even if they had transplant glomerulopathy, if they had a lot of interstitial fibrosis and tubular atrophy, these patients did poorly. So we're trying to simplify BAMF as best we can over the years, but it took 3 decades to make it complicated. Hopefully it won't take 3 decades to make it a little bit more simple. And with that, I'll conclude. Thank you very much.
Thank you, Professor Mark, for taking us through this BAMF's journey. It's been absolutely fascinating, and it's really contributed a lot to our understanding of the antibody-mediated rejection. So the chronicity index is definitely a welcome addition, because a lot of us were at sea as to, and often in doubt what to do. Do we also have any activity index akin to the lupus, the aggressiveness of immunosuppressive therapy that we could use?
Yeah, this was actually based on, the idea for this came from lupus. In lupus, if you look at the older, the ISN-RPS classification back from 2003, 2004, they had terms like active, active/chronic, and chronic. And active, we clearly know what active means, and chronic, we know what chronic means. But when you had active plus chronic, that can mean a lesion with a lot of activity and very little chronicity, or a lesion with a lot of chronicity and just a little bit of residual activity. And so the term chronic active was difficult for transplant clinicians to know how to treat the patients. Yeah, it was chronic, and yeah, it was active, and some people interpret it as only being equivalent to chronic. But it was not granular enough to really provide the treatment information. So chronic active antibody-mediated rejection could be a floridly active lesion with early transplant glomerulopathy, or advanced transplant glomerulopathy and IFTA with a little bit of residual activity. And that's what we're trying to do. The same thing as lupus here, and also going to investigate activity indices as well, and try to make this applicable for TCMR as well as AMR.
Right. Thank you once again. I think because of constraints of time, we'll leave the further questions over T.
Yes, and in the meanwhile,
the organizers,
on behalf of the organizing committee, I would request Dr. Arpita Rai Chaudhary ma'am to please facilitate Dr. Mark Haas for giving us his valuable inputs, and of course being here physically with us as well.